Again, thanks for staying on. This talk is a lot of fun for me to give, and it's my time to humble brag for the AIHA. And in fact, sometimes I lose sight of how productive that we are here at the AIHA. And I want to just tell our members a little bit more about us and about the things that we're doing, but also how these things are supporting the overall research architecture in the space. And you've heard a little bit about it thus far. I want to first start off by just thanking our AIHA board of directors. Many of these individuals you've seen over the course of our talks and interactions, Andrew I, Veronica Williams, Lisa Devereaux, and Luke Britt have been tremendous assets to our organization in terms of driving mission and thought process and thinking how we attack this disease, but also how do we provide the best support for our members. So I want to thank them, and they give a tremendous amount of their time, so thank you. I also want to just bring up Aaron as well. Aaron is a true asset. I think many of you have had conversations with Aaron offline. I don't know where this organization would be without her. So Aaron, I want to personally thank you. I'll highlight this organization only has one paid employee, and it's not me. Everyone else that you see is volunteer. And again, Aaron brings that all together. She is a master at organization and productivity, and she keeps me on my toes. And I truly believe, again, much of our programming would not be possible without her. So Aaron, I just want to take this moment to thank you as well. We also interact with our medical board, and this is a really important piece for our nonprofit. We really think that thought leaders and experts across North America, but really the world, should be a part of our organization to kind of help steer to support the patients the best, but also to develop that programming, things like this conference, but also research initiatives as well. And I'll tell you, among these doctors, they have opened up their email and their phones to our questions and providing answer and guidance. And when things are not clear, we have good discussion about how to best bring things to patient consumption and make sure that we keep our patients on the cutting edge, when sometimes even doctors can't even keep that as well. So I wanted to thank them and give them special recognition as well. Our members are really at the heart of the mission of the AIHA. As I told you, we really want to provide support and hope, and even more beyond education, but research and development of new therapies. But as of now, we have over 3,000 registered members, and this is a heat map. It's a few years old, but it does highlight where people are, at least in North America. We have many members out of North America, or out of US and North America and Canada, but also overseas in UK, Germany, among others as well. And even in the Southern Hemisphere, which I'm always impressed and surprised about. We have a very robust social media channel. In fact, we have over 4,300 members there where we give education, but also have patients ask questions and we give feedback. But really one of the great things I see about our organization is really the patients. And again, having patients teach patients is a really important piece, and that's a part of the support. So I think we have bred that culture into the fabric of this organization. I'm just really, really proud of that. Our organization is generally female, but again, this mirrors the composite of the patients we see in the clinic as well. But I do think that we still need to maintain at least some dedicated programming for our male patients as well, because I do sometimes believe that they get left out. This isn't just in our programming, but also with research as well. Some new initiatives and fun things that we've done this past year. Aaron helped place all this together, something called the New Patient Toolkit. We really set this up with the aim to simplify someone's introduction to AIH and really just provide the most up-to-date, useful resources in one-stop shop. We hear it time and time again, and everyone that's watching today can relive in their head what it was like to be diagnosed, particularly if you were diagnosed years ago or just were recently diagnosed. It can be a very turbulent period. I've heard more and more that at least our organization has been a bastion, at least of hope and education in those times. And again, something I'm very proud of, but at least if you haven't looked at this, I would advocate. In fact, I saw a member comment earlier today that the patient toolkit was really well done. And again, that is Aaron's contribution as well, but where we see a lot of the AIH basics, introduction to our support groups, how to find the right doctor, but also optimize those visits and those key questions, because I really think that's training that we just you don't get as a patient until you're thrust into an illness that is severe or at least chronic. And again, arming patients with that, I think, produces more meaningful interventions with their doctors as well. And again, more fruitful interventions hopefully results in better outcomes as well. You can find that toolkit on our website, which I think we've alerted everyone over the past year. We've updated our website. I think it's really clean and polished. One thing that was exciting recently is we were able to provide a number of our resources in Spanish as well. And just here's the highlight. People of color or other ethnicities are still touched by this disease. And the Spanish population has been underserved, at least in autoimmune hepatitis. So we found this to be very important. And we were very excited to pursue this. Beyond doing that with our website as well, we were able to create a brochure to be used for local doctor offices. I think I've shared with many of you my initial lack of interest in providing pamphlets, but it's funny, when I diagnose AIH patients, that is the first thing everybody asks me for. So now I have a pamphlet that was created with funds from a small grant from the drug company Novartis. And not only does this pamphlet kind of give the initial introduction to AIH, but also our organization, what we provide, but also this is provided in Spanish as well for patients that need it. And our hopes is that this information is distributed across multiple offices throughout the country, not in just major academic medical centers, but in places where AIH is, even in the local community clinics, because I still firmly believe those patients are out there as well and could benefit. Health equity has been really important. And I want to highlight, and I think this came up earlier, that very few scientific studies of AIH has been published that include minority races. And in fact, there's really only a handful of published reports concerning Black patients. And these patients, when you look at them, it's been about 150 patients in the literature. That's excluding Dr. Bitterman's new publication, but the outcomes are less than favorable. They seem to be diagnosed at a younger age. They have a higher risk of diagnosis of AIH, have cirrhosis at diagnosis more often. And they also have higher needs for developing the need for liver transplant or dying-related AIH as well compared to white patients. Same thing in Hispanic population, much like I alluded to earlier. The ones that have been published that have Hispanic data in it, we see that it's just few, but we also see those patients too are more likely to have cirrhosis at diagnosis as well and need hospitalization for AIH. So in 2021, we convened a group of committed patients, doctors, and researchers to form our first diversity, equity, inclusion committee, and really just to begin thinking more intentionally about this topic, specifically health inequity in AIH. And the committee started to educate our members. And beyond this important talk, we even hosted a health equity community conversation at the American Association for the Study of Liver Diseases this past year. And it was very exciting because it was very well attended. But it was a very good discussion about the importance of this, not only in AIH, but among other autoimmune liver diseases as well. So it was really great to be a front runner in this conversation. Further, in research that we participate in, we really are committed to ensure that we promote the inclusion of patients of color to better understand AIH in those groups, particularly in those underserved. But we also then look forward to sharing that work with you as well as it progresses. As an organization, we also wanted to create a focus on patient and caregivers. That just goes without saying. But as we've seen, there's been a cultural shift in clinical care and the provision of medical care. It's a movement that is, you may have heard it, it's called patient-centered medicine. And it's really in that model that healthcare takes patients' goals, their preferences, and their values into the utmost consideration. That is what is important. And this idea conceptualizes the statement, nothing about me without me. And as an organization, we found that a similar cultural shift in the research model, so where research is being done on disease, has been much, much slower. And I'm not sure why, but it may be that society doesn't see patient responsibility to participate in research as obvious as the responsibility to participate in their own medical care. But I think, unfortunately, this culture does exist, and it's where research is performed on patients, not with patients. Where patients are regarded as data sources and not protagonists in their own research for their own disease. But I think there's been initiatives to see this change, but unfortunately they end up tokenistic. And I think as an organization, we really wanted to change this. And this figure here shows where and how patients can interact with a study team during any research project. It's clear that well-informed, educated, or even expert patients or AIH patients in this setting are going to be well equipped to participate in research within the scaffold of the research model, including before, during, and even after a research study is completed. I think it's important patients are present here throughout, as scientific relevance, or what I think is the most important piece in research or AIH, does not equal to what you think is the most relevant. And so as an example, I think patients with vast disease knowledge or experiential knowledge with this disease can help shape our research priorities and are likely of really great help when it comes to design these research questions, finding ones that are most applicable to patients. And really this pays off in many ways, such as more relevant patient-related results, better recruitment and retention, and even less research cost. And patients should be engaged throughout the research study as well. And this includes at the end, where we need to assess their experience with research, how we inform them of results, both the positive but also negative results too, and assess the overall experience. You know, the transparency and completion of these principles may result in better recruitment, as I said, but also may include more variable or diverse groups of patients too. And I think another byproduct would be the creation of more knowledgeable expert patients, which I said at the beginning. This is really dependent on those expert patients. And those are the patients that are willing to be active in research, collaborate with organizations like ours, industry or regulatory bodies, or even pharmaceutical associations as well. So how did we get patients into that driver's seat? And again, we've worked on making expert patients, but we had a conference back in January of 2022, and this was a patient and researcher summit. This was a summit that we invited approximately 20 to 30 patients to, along with many researchers and clinicians that are considered thought leaders, but also have significant practices where they treat and manage AIH patients, where we actually came together as patients and doctors to find a model or approach to AIH that addresses some of the biggest gaps in this disease. And what we found was what I told you earlier: treatments have not been optimized and we need new treatments. We also need to pay more attention to the quality of life of our patients and not just be so focused on laboratory results. And we need to look at underserved populations or diverse populations, as the data is obviously very, very limited. We then came up with this idea, and I shared this earlier too: what is an ideal therapy? And that would be medications that tolerate well, control inflammation, they improve the quality of life, and these have been tested in diverse populations. But also we see progression or regression of fibrosis and improvement of symptoms. So it was a very fun exercise. It's something that we're going to do at least annually, we'd like to, where we have a discussion where we have at the table researchers, pharmaceutical companies, and most importantly, patients. Other strategies we've used, just 2 publications that we've had in the past 2 years, where we took an AIH members question on social media, someone asking about CBD for AIH symptoms, or what supplements are you using? Are they safe? And we did a survey-based study. And you can see we did these over varying amounts, but we have what's called the Institutional Review Board of Scientific Study here at Indiana University. We propose a study, we make a protocol, we make a survey, and then we distribute it to you from the comfort of your home. Despite that this is patient-reported data, it can be very important in terms of understanding direction and overall strategies. So as we found in using this in very short amount of times, mind you, when I tell colleagues that we did a rare disease survey in 10 days and we had over 370 patients, their minds are blown. So in fact, we love to utilize this because, again, it's a great way to create also new hypotheses about how this drugs or therapies or some other aspect is behaving within this group of patients. And we found novel findings that we reported and really helped to add to the incremental benefit of the AIH literature. So this is something that patients did. We also have been using our support groups, which Aaron has highlighted, and we did a call out that we have a number of support groups, but these in themselves can also be support or research tools, depending on how we're using them. In fact, more recently, we did what's called a qualitative health study looking at diet and its impact on AIH symptoms. And we came up with a questionnaire to really highlight how these patients, in a very highly granular way, how have patients seen diet to be important in the management of their symptoms, but also maybe how has it helped them to consider why they developed this disease or how they deal with side effects of medications like prednisone. We use this another way too before with a publication that Dr. Montero talked about with how patients perceive quality of life and how those barriers really limit a lot of the normal day-to-day behavior like relationships, their work, their career, how they travel and how they exercise. One of our crown jewels that I think someday will be clear is our registry that we launched last year. Now, registry, when I say that, it can be a fairly benign term. Not a lot of people probably understand that. But this is a group of patients have decided to join a formal research study hosted by the Autoimmune Hepatitis Association as a way to better understand some scientific question. In our case, I'll highlight, we're looking at things such as quality of life. This registry with Kelsey Green, who's also helping us with the call today, she is our research coordinator for this registry. Thus far, we've been able to recruit over 100 different patients and collected quality of life metrics, in which I'll share in a moment. But really, we've made this registry really easy for people to join, and it's a way for people to participate in significant academic research, again, without having to travel, and it's completely free. We have patients go through our website, and this can be found there, where you actually review the study materials and what we decide that what we're thinking about doing. You then reach out to us through this email. You meet virtually with a research coordinator. It takes a very little amount of time. You then enter the registry and you complete the surveys. And these are all linked together and gives a really nice snapshot of an AIH patient, their disease course, their history, their treatment, but also then tie that into their symptoms, what they're currently experiencing. And we would like to expand upon this, which I'll show you momentarily. As I told you, we've had over 100 patients enrolled just in the past 7 or 8 months. We haven't been pressing this too tremendously because we wanted to see how it was perceived by the community. We also wanted to see how we could better utilize this data for a number of things, which I'll show in the next slide. But we see the average age of patients participating in the 50s, the average age of diagnosis of late 40s. So we're seeing patients with an average duration of disease of 5 years or more. Unfortunately, though, this is mostly Caucasians. We would like to see more people of color, and I think this would be a great avenue for our diversity approach to really making an impact on this disease. And as we highlighted before, a lot of those patients are still taking steroids, which again continues to concern me. In terms of our quality of life assessment, better understanding of this also helps to push those research questions and look for better therapies. But we see anxiety, depression, fatigue, sleep issues, social role issues, and even pain problematic in over 1/3 of patients, which is concerning to us. Ultimately, these are the pieces that, again, many of my patients beg for me to improve. They're not so mindful of those labs that I follow every couple of months. They want to know when the lives are going to get better. But again, for further insight into this, I ask for you to consider joining. The registry email is here, registry@aihep.org, and our research coordinator will reach out to you. What we think in the way that we'll utilize this registry as it grows, and again, we hope to have over 250 patients within the next year. But I think it can do a number of things beyond understanding the symptoms and really advocating the need for better therapies and therapies that don't depend on corticosteroids. But we can actually start to identify patients that are hard to treat and dependent on steroids. And in fact, then you can actually look at those patients and use that as a recruitment tool for research trials or clinical trials. And that's something that we would love to do, but also pave the way to help pharmaceutical companies to target patients, at least to invite them to future studies or see if there was a way to make it feasible. Another avenue that it has tremendous interest is the consideration of biomarkers. And in fact, biomarkers can be a lot of things. They can be lab tests, they can be experimental tests, things that are not widely available. But how do you actually judge something like AIH with just a very simple test like fibrosis or inflammation? So we use ALT in the liver clinic as a biomarker for inflammation, but there may be other biomarkers that we just don't know about yet. Ultimately, I think our goal would be able to pair this registry and connect it with either whole blood or DNA samples as a way to actually start to look and survey for biomarkers. An important question that's come up across our desks is that with pharmaceutical companies, before they end up doing studies and looking at theoretic compounds to treat AIH, Some of their initial investigation is to look at biomarkers and to see if certain pathways are involved in this disease and whether the drug will work. We've gone through the schematic, and now everyone's well versed that autoimmune hepatitis is related to this autoimmune attack of the liver, which causes fibrosis if not controlled, and is complicated by a lot of these symptoms in a lot of patients. We give immunosuppressant therapies to minimize that inflammation. I talked earlier about mesenchymal stem cells, and I'll tell you that this is one of the most exciting things that we've ever had with this organization. But most recently, with collaboration from an outside institution, here at Indiana University, we are currently priming for the development of the MSC treatment protocol to use for the treatment for hard to control AIH patients. And this is actually, we chose this for a reason. If you look at the guidelines, again, these are the guidelines for AIH that were released by the American Association for the Study of Liver Disease. And again, those guidelines suggest that, as I remember, if I told you, Tregs, but also MSCs may be a strategy to restore immunotolerance, restore that inflammation back to normal. And again, what we have seen with mesenchymal stem cells is that these have been very well tolerated in other disease states. And in fact, we're excited as we are moving towards the protocol development and submission to the FDA, just as an update. And we've had many generous donations from our members to make sure this happens as a reality. So in fact, this will be the first time, at least for our nonprofit's history, that we've been able to successfully dream up with patients, but also launch a therapy or an investigational trial to see if it has any impact in the control of patients that need it most, those that are hard to treat. And more to come on this, but the idea, as I told you before, is by giving MSCs, these cells can go to the liver tissue and can control local inflammation. They also pump out packets of anti-inflammatory molecules as well, which can really help to mitigate inflammation. At least that's the hypothesis. The idea is that this will be given in addition to other therapies. But again, remember, we're targeting patients that are hard to control. In terms of the study timeline, we'll keep you all abreast of this as well, but we suspect we'll be submitting our protocol to the FDA here in the late summer. We'll hear back from this application too within 30 days of that. They have 30 days to respond to us. And then here locally, we're going to work to get everything in line that we can actually start to recruit patients using specific inclusion/exclusion criteria, and then hopefully with our first dosing sometime in the fall or early winter. Again, it's a very exciting moment, and again, we're very optimistic. The patients that should be interested in such as this, and I think one of the strategies here, at least at our center, the idea is maybe patients throughout the Midwest would be available, but as I highlighted, we'll probably have multiple clinic visits that patients have to present here for these infusions. Again, it will be over the course of a finite time, but the idea too is if we show proof of principle that we can actually apply this to longer treatment strategies in the future, depending on how things go from our initial phase to a trial, which is really looking for proof of concept. But patients that are having abnormal liver tests despite persistent steroids or intolerance to therapies, and again, we really want to see if we can somehow highlight and recruit more patients of color just to provide resources for those patients that have historically been underserved. So here is kind of more of a final call to action. I really ask that all of our members, those that are still on the call today, to think about ways you can participate with this nonprofit. I think one of the most simple things you can do, and I was really excited, I saw this as a comment earlier, a doctor at Kaiser Permanente had told whoever left that comment about organization. I think we need to be more prolific. And in fact, if doctors know, they're going to tell all their patients about our organization. And in fact, we lessen the burden of those doctors in the clinic. Some may say that actually we maybe make it complex because we promote more questions to be answered. But again, a lot of the simple things can be ascertained from our website. And then also the support that patients can get from each other. The leadership, the local support groups have been true leaders to the patient community. And I want to thank all the support group leaders that, again, chimed in and told you when everybody meets. Again, these quarterly group meetings typically, I know, have been significantly impactful, at least for my patients. And I've heard other stories of this as well. One thing that I've been very excited to be a part of is I usually join the new member group as a way to to hear how people are getting diagnosed, what doctors are telling them, but also just making sure they're plugged in and they have a good disease understanding. But I would love for everyone to consider other opportunities, whether it's community membership on our Facebook page, but also any volunteerism, particularly with callouts that we have on our organization as well. And then finally, one of the tougher pieces is giving. We are a nonprofit. We are a small nonprofit, but we would not exist without the support of our members. There's a number of different opportunities, ways to give. There's peer-to-peer giving and maybe setting up fundraising on birthdays through Facebook. We have a really robust year-end fundraising campaign. We do have members that make individual gifts, but also members that choose to give through things such as Amazon Prime. Some companies do matching, but also outside of finances, people have other skills and talents they can give. So if you can think of anything that you think that we could benefit from, we would love to hear from you. So in conclusion, I just want to highlight we are proactively working to improve the education, research opportunities, and really even promote a brand new therapy in this disease. We have some key focuses, and you've heard a lot about these. Underserved populations are really important, but also those patients that also need new therapies, those hard to control patients, and those patients that suffer from poor quality of life related to this disease. If you're looking for an avenue to contribute beyond all the participation with our organization, think about joining the AIH Connect. This registry, again, this is kind of foundational level, but I think it could be great. And it would be a great unifying strategy that, again, is for patients, by patients. We need more expert patients. And in fact, it's those patients that are going to drive the patient-centered approach to research. And really, at the end of the day, it's really the patient's plight that matters most. So I thank you all for being members.